This is It's Not In Your Head podcast with Dan and Jez. Dan is a doctor and Justine a pain coach. We've come together to find ways to manage complex chronic pain better for both patients and providers. Hey there, welcome to another episode of It's Not In Your Head with Justine Feidelson and Dr. Dan Bates. Hi there, Dan.
Hey, Jess. How are you?
Swell.
Swell.
That's what you say when you're not swell, when it's election week and time change and all sorts of crazy stuff. So we're hanging in there. That's the truth. But at least we don't have to do an episode on flaring this time. Doing a lot better than that. Thank you, Dan.
Yeah, good.
Yeah. Today, what we're actually going to get into is a bit of a more general overview on sleep. But really, it is building on the sensitization algorithm episode that we did quite a while ago at this point, which we have since renamed to widespread pain and things that don't make sense, essentially, because that's what central sensitization is and presents like before you realize what it is. And so similarly as how the last episode on pacing was really treating the energy management or lack of energy, right, that you have, which is synonymous with fatigue, with central sensitization. Sleep and recovery is also really looking at treating that fatigue as well as the cognitive impairment bucket that develops with long-term central sensitization or widespread pain. So we're going to get into how you can manage sleep and your recovery and the behaviors and actions that you do during the day that also affect sleep a bit better from a conservative perspective, as well as when symptoms are very intrusive or actual sleep disorders, how would you approach treating them and where do you go from a medication or a referral perspective? So we'll dive into some of the basics around sleep to begin with, and then we'll go down the path of how you actually approach treating them depending on how intrusive those symptom buckets are. And really what we want you to also see out of this episode is how critical and important sleep is and the role, it has on pain, the link between pain and sleep, and how it's really a non-negotiable. Unfortunately, when you have central sensitization, you really cannot thrive long-term if you are struggling in this department. So it's a really, really important one to understand, wrap your brain around, and have some clear-cut strategies to improve.
There you go. There's an intro. Like it.
That's the intro.
This is a good one to do today as well because, I am definitely got a bunch of cognitive dysfunction going on.
Dan's sleep deprived.
Because of my sleep last night, which was rubbish. And it's also rubbish not because I was silly and got on the terps, but because, I've got a upper thoracic thing going on at the moment because, it's what happens when you go and do too big a session at the gym.
Much.
And so my sleep last night was rubbish. So
felt it a little bit.
We can see how my cognitive dysfunction goes. What I did want to kick off with, because I think this is a really important part of central sensitization. So let's just review what the algorithm is so that everyone sort of gets their heads wrapped around. And we'll point out how sleep disturbance fits in to the central sensitization algorithm and then how you can kind of think about your sleep disturbance, because I think it becomes a really good way for people who suffer chronic pain to be able to tell others what it actually feels like outside the attribute. So central sensitization you can think of if you split it up into 7 main buckets. So those main buckets are sensory hypersensitivity, sleep disturbance, fatigue, cognitive dysfunction, mood disturbance, dysautonomia, and then motor dysfunction. And so if we break each one of those down, sensory hypersensitivity is hypersensitivity to pain. So when that pain is widespread, you present with symptoms similar to fibromyalgia. When it's regional, you may then have symptoms like temporomandibular joint pain or migraines. Although I think it's important to remember that those disease processes have their own process. When you're essentially sensitized, you present like them. And we may label you with them, that's for sure, because we don't know what's going on. But they have their own separate disease process. I think the easiest way to think about that in this setting is looking at something like POTS, where you have the tachycardia. That is an absolute disease process of its own sort. But what you present with when you're centrally sensitized is orthostatic intolerance, which is lightheadedness, dizziness, chest discomfort, etc. when you stand up, and you get tachycardia. And so that presents as POTS, but POTS itself is its own disease process. So anyway, back to hypersensitivities. So then you also get hypersensitivity to light, sound, smell, taste, touch, heat, cold, you get food intolerances, and you get balance disturbance within that. Within the sleep disturbance bucket, which we'll dive into deeply here, it's difficulty getting to sleep, staying asleep, and getting back to sleep. You get unrestful sleep. You get the fatigue component, which is, depending on how long it lasts, you can get a thing called post-exertional malaise. We'll talk about that in more detail at a later point. You get cognitive dysfunction. So you get difficulty with concentrating, difficulty with thinking, and difficulty with remembering. You get mood disturbance, so anxiety, depression, et cetera, et cetera, et cetera. And then you get your dysautonomias, and that's where you get abnormalities with sweating. You get your orthostatic intolerance, like we were just talking about. Juz is going, why am I sweating so much?
I'm not even nervous, but my underarms tell a different story. Sometimes I swear I forget it's not just Dan and I talking, and everyone can listen to
She's hiding her pits today, so it's sort of like...
If you don't laugh, you'll cry. That's the truth.
All right. And so orthostatic intolerance, that's where we get our POTS diagnosis. That's lightheadedness, dizziness, tachycardia, unstanding. So you then get gastrointestinal symptoms, so abdominal bloating, nausea, vomiting, diarrhea, constipation. That in many cases gets labeled as IBS. You get bladder symptoms, so increased frequency, urgency, bladder pain, sense of incomplete emptying, and you get reproductive dysfunction, so the reproductive symptoms, so dysmenorrhea, menorrhagia in that setting. And the last piece is then motor dysfunction. So within that bucket, the way we think about it goes restless legs. You'll find today that when we talk about sleep, the restless legs goes into sleep for all the sleep physicians. So restless leg syndrome, which is this continual moving of your legs and you just can't make them stop, that comes on particularly at night. You get cramping, tremor, thing called myotonic jerks, which is, as you're going off to sleep, like so things annoying. Just arms and legs
sudden. The joke of others used to be like, it's like physical Tourette's, when my leg would sort of very dramatically jump like that.
There you go. Physical Tourette's. That's a nice way to think about it. Term, and then the last piece is what probably fits into this bucket is functional neurological disorders, which are very much defined as having a motor component to them. And they are a neurological disorder that we just don't understand what the cause is. So that doesn't mean, once again, it's not in your head. It just means that we don't know what's causing it, which is a different thought process. All right. So that's how it fits together. So let's finish off with this piece around how do you use sleep to explain your pain to somebody else? Okay. So if you think about sleep disturbance, so if you've ever done shift work, if you get jet lag, how do you feel when you're jet lagged? So number one, you're tired. So there's the sleep disturbance piece. The next piece with that is that you can't get to sleep when you want to get to sleep. So you go to sleep late, or you go to sleep early, or you wake up early and you can't get back to sleep. So there's, there's our sleep disturbance component. And most of the time you've got unrestful sleep during a period of, jet lag or sleep disturbance or shift work disorder. So the next piece is then you get fatigue. So that's our next piece. You also get alterations in your sensory hypersensitivity. So you might notice that you're more sensitive to light, you're more sensitive to sound, you're more sensitive to certain foods when you're jet lagged or when you've got sleep. So you just don't feel like eating this or that. And your tummy might just be off. I just feel a bit crook in the guts.
More nauseous, more ick.
More nauseous. Yeah. Mm-hmm. You get more irritable. You might be a little bit more anxious. You might be a little bit more flat, which is common. So there's our mood disturbance bucket. It's definitely harder to think. Like anybody who's done that sort of Yeah. You can't think, can't concentrate, can't remember, can't think.
Yeah, you don't want to do a presentation right after you get back from a trip on a different time change. Right?
Or when you fly interstate, land, do a presentation. It's never never the best.
Not ideal.
Option. Your dysautonomia pieces, they fit in sort of with alteration in gastrointestinal function, alterations in probably bladder function, etc., where you get your dysautonomia type symptoms, and then your motor function dysfunction. They're probably a bit harder to see. One thing that you do see it in is you do see it in athletes. And so athletes that go to different time zones, certainly in the early period, do not perform as well. Now, whether that fits into a motor dysfunction bucket or not, I don't know. But, it's kind of the way I sort of think about it in some ways. So that's how jet lag, sleep disorder sort of fits into essential sensitization bucket. So if you've got chronic pain and you're essentially sensitized on top of the, perpetual ouchiness, one way to be able to explain how you feel, because it's very hard to explain how you
Right.
feel, is
Right.
think about being jet lagged. Think
Right.
about being really, really jet lagged.
Yeah. Not
As
America, West Coast to East Coast, 3-hour jet lag.
Yeah,
like
yeah. So
real
go
jet
like
lag. Right.
go Melbourne to New
Yes.
Orleans.
Yes.
Like that. It's hard
Yeah.
to get more jet lagged than going
Yeah,
Melbourne
yeah.
to New Orleans, which I have done, and it really hurts. But that's a great way. So
Yeah.
all the other symptoms outside of, hey,
Pain.
this hurts, because people understand the pain to a certain extent, but they don't understand the sleep disturbance, the mood disturbance, the fatigue,
Right.
my guts
Cognitive
feel just
dysfunction.
weird,
I
the
can't think
cognitive
straight.
dysfunction,
Yeah.
all that sort of stuff. The other sensitivities,
Right. The lights bug me more.
the lights
like that.
bugging me. Can you turn down the lights? Like
Right.
that stuff. It's a great way for other people to understand, what are you experiencing times 10.
Right. All the
That
time.
is all the time, that they will have experienced transiently. So
Yeah. It's an empathy exercise.
absolutely. Stick that in the back pocket.
Yeah. The
for someone-
communication.
for the communication
bag of
back pocket.
things.
Add it to, do you want to swap, for those people that tell you it's in your head.
Want to trade?
They want to trade.
No.
Anyway,
Yeah.
Ripper. That is such a great one.
Early piece of merch for sure. We're getting there. We're getting there. At 50 episodes, we should have a deal. When can we start merch? We'll see.
Okay. No worries.
You guys got to
Merch.
download that. If you want merch,
All right.
listen to more episodes.
All right. So let's move on. All right, Jazz, can you break down? Let's just get into some of the technical bits. And what we'll do from here is we're going to go into the technical components of sleep. So we're all sort of talking about the same stuff.
Right.
I'm then going to run through sleep disorders briefly, although I am definitely not a sleep expert. So it'll be, somewhat cursory. And then we're going to get into the conservative components of how you manage your sleep, which Jazz is an absolute superstar. So
unfortunate necessity in this department. Yeah.
Superstar
taking a long time.
by
no choice.
Learning, by no choice. Okay.
Yeah.
All right, let's go. Sleep cycles. What are they?
All right. So the point of getting into some of this too is not just so that you understand the basics of sleep, but so that you can see how, if these things are not being met or you're struggling to get this type of sleep, it is going to affect you in these other ways that then have to be managed with either conservative or more interventive strategies. So to begin with, sleep has 4 stages. The first one, stage 1, is the non-REM light sleep stage of sleep. This is the one where you're easily awakened, You can kind of feel yourself coming in and out of sleep. Sometimes you toss and turn a lot longer than you would want when you're trying to fall asleep. If this is the stage that you get stuck in a lot or spend a lot of time in. If you're someone who has like a Garmin or a sleep recovery sort of tracking device, you'll notice often that your light sleep or your non-REM is where you spend a lot of your time overnight, way too much time, and you spend little in REM or the other stages, which you will see in a second why that's problematic. Because then in stage 2, that is our slightly deeper stage of sleep. That's where your brain waves and your heart rate actually starts to slow down. Stage 3, that's the deep sleep or the slow wave phase of sleep. That's where we have muscle and tissue repair, growth, immune function is happening during that period. And that's where all of the sort of restorative and regenerative aspects of sleep come from that help you feel more refreshed when you actually wake up in the morning. And then, as we've all heard of, REM sleep is a very important 4th stage of sleep, particularly when it comes to cognitive dysfunction, because that is where learning and memory consolidation happens. So that's where, when over all the years with a brain injury, my severe years of accumulated sleep debt and sleeping 0 or 1 or 2 hours of night for weeks and months, on and on, creates as much of a cognitive clusterfuck, pardon my language, as the injury to begin with. And then you pile on med side effects. And that, you start to create a very muddied picture of what is from what. And there's no way around the impacts lack of sleep has in those then departments. And so you can't treat those things with other ways if you don't also treat the piece that sleep or a lack of sleep is responsible for. So ideally, we should be going through 3 to 5 sleep cycles over the course of a night. One would want to have uninterrupted or as close to uninterrupted sleep as possible, especially once you get past that first kind of toss and turny phase, because you need constant sleep for all of those body systems to recover effectively through these phases. And from a cognitive learning perspective, again, sleep is what helps you move recently acquired memories over into long-term storage. And if you're not doing that, it's like a backup. It's like a traffic jam. You can't put new information in if the old one sort of has nowhere to go or to be stored. And so it's critical to be able to free up this type of short-term memory to make room for new information if you want to learn. And if you can't, it makes learning really hard and tiring and overwhelming. And I can't stay focused on a paragraph. I remember trying to read, for fun. And it was just frustrating and exhausting because I would get caught reading the same, line over and over because I didn't have the focus to pay attention to begin with, let alone to then retain what I was trying to integrate. So missing stages, obviously you can see how leads to significant functional deficits, particularly in cognition, mental acuity, and then overall energy, which quickly starts to affect, your mood as well. But this is why sleep has such a dramatic impact on pain, because we've talked about capacity a lot. We talked about it in the pacing episode a ton. And if you have no capacity or zero, you're overflowing into the flare episode, right, bucket of things. So sleep is crucial to give yourself a chance, essentially. And people that I see who really struggle with out of control, widespread sensory sensitization, and the other buckets of things all struggle with recovery. And that's why they have such a lack of capacity and they cannot change that baseline.
Yeah. I think that one of the important things there is that pain and sleep have a bi-directional relationship.
Yes.
And I think we effectively are talking about pain here. We know that, you look at chronic sleep deprivation results in increased risk of Alzheimer's, other neurodegenerative diseases. We might focus on that at a later point in time because it's kind of interesting. And if you look at the chronic pain data,
more long-term consequences.
Yeah, it fits with all that stuff as well. But it's a bi-directional effect. So that means that pain affects sleep affects pain. Yes. And so you effectively need to manage them at the same time. And so, I think that pain obviously makes it more difficult to get to sleep and it's more difficult to stay asleep. Like last night, my back, every time I rolled over, I wake up. Yeah, poor Dan.
Poor Dan.
I don't know. It was very annoying. Very annoying. I think it was annoying my wife more, actually. So
yeah, probably more Katie.
Yeah, poor Katie. And the other thing that it does is that pain affects your sleep architecture. So Juz has just gone through each one of the sleep phases. And so what it actually does is it will decrease your shortwave sleep, which is the restorative component. Right. And it'll also decrease your REM sleep component. So not only is then, the pain is worsening your sleep, your sleep,
quality.
That's the word I'm looking for. Right. See, there's my cognitive dysfunction from my sleep dysfunction last night. Yeah. And the last thing, obviously it affects duration. So, Juz just highlighted, days of having 1 hour's sleep are not particularly viable. In the other direction, what a lack of sleep does is that alters your sensory hypersensitivity. It drops your pain threshold, so you have an increase in your pain. Right. And so that's real, like that in itself then, so now
it's harder to fall asleep even, and then that makes pain even worse, So.
And even if it was in the setting where you're like, okay, your pain's under control, but then, you shift your habit or you shift whatever, and then it's a couple of late nights in a row, and now what we've done is you've dropped your pain threshold and away goes your pain. So that's important. It alters your normal internal pain management system. So it alters your descending inhibition. It alters, I imagine it will also alter your brain dysfunction. Hey, take that out.
No, this is only fair. I'm enjoying this. This is how I am all the time, Dan. This is the best. Earlier on, I was like, it's not fair that I'm not able to be my best during the podcast. And Dan's coming out here with Dan's brain. And I'm like, I can keep up.
Dan's brain has...
It's okay. That's why it's a 2-person podcast.
Yeah. Okay. Great. Thanks. Look, you obviously get emotional and cognitive alterations when your sleep is off. So if you're already anxious and your anxiety drives your pain, I had someone in during the week who's the primary thing driving their pain was their anxiety. And I was like, don't spend money on me. Let's spend money over elsewhere. Right. And get this sorted out.
Bring that down.
Yeah. And I think that it's important to recognize that it is that bi-directional effect. And you might not recognize that you've had a change in sleep quality or sleep duration that has then affected your pain.
Right.
So it's one thing to keep an eye on.
And that's a good example too, where then someone goes and does some movement, right? And it's like, oh God, the movement blew me up. And it's like, maybe it wasn't the movement. Maybe it was your recovery status or the sleep like quality around that then changes your capacity. And that has a different impact on your system because you have a lower threshold. That's where people get in trouble with like the weekend being different from a sleep schedule perspective than weekdays too, because it doesn't take a lot. Yeah.
Yep. So from a mechanistic perspective, although we've not dived into this from a central sensitization piece so far, but central sensitization is likely a neuroinflammatory process. And what sleep disturbance does is further drive that neuroinflammation. So it increases the release of inflammatory cytokines. It does this thing to these set of cells called microglia and astrocytes. These microglia and astrocytes, they are the support cells within your brain and your nervous system, and it makes them more pro-inflammatory. And it also alters, the response of these receptors called inflammasomes. And so inflammasomes also drive the inflammatory process across multiple components of your brain, your nervous system, and your body. So so there's a direct link between altered sleep mechanistically then through a neuroinflammatory process and then into what we see as central sensitization.
Yeah. And this too is right. There are physiological reasons for why your pain gets worse. It's not because at times you just imagine it to be worse. Like this is how it happens. Yeah. And it's very frustrating. And it's easy to, right? As a pain patient, it's very easy to feel how much pain affects sleep and how hard and how frustrating it is to fall asleep because of pain. Pain is often worse at night too, but you'd be surprised at somehow how hard it is for people to see how much sleep does affect pain. So it's good that we ran through that because it's even more. Lack of sleep affects pain even more than pain affects sleep, as hard as it is to fall asleep. So it's a big deal.
It's annoying.
All right.
Anyway, got to treat both.
I wish it was not. Yeah, I wish it was not.
All right, let's break down some of the medical stuff because I think that if you've got a medical diagnosis that is a sleep disorder, you need to be dealing with that. So I think that's important, and you need to be able to recognize that, hang on, I actually don't have, sleep disturbance because I'm centrally sensitized. I have got
I have an actual sleep disorder.
I've got a sleep disorder. And that means you need to go and talk to a sleep physician who are smart people to deal with sleep disorders. So it's kind of interesting area.
It's an easy sort of obvious point that just piggybacks on the sleep cycles where, right, then your sleep needs are going to vary depending on your age. If you're younger, you need less. If you're younger, you need more. If you're much older, you can get away with less. If you're kind of middle-aged, you need that typical 8 hours. Ideally, you'd want between 7 to 9. If you have low quality sleep, you have to be spending at least 8 to 9 to even get close to the lower range of 7. Think about, the time you spend in bed, the total time in bed versus how recovered you feel. Do you not feel recovered when you wake up in the morning? Are you not even close to these 7 hours? I work with so many people who are like 4 hours, 5 hours, 3 hours. Oh, on great nights, I get maybe 5 or 6. Again, that added up over time is not going to work either. And so you have to look at yourself and go, am I meeting these even bare minimum requirements? And am I maybe really far off? Because that's when you need to start looking at sleep disorders, apnea, snoring, some of the other things that, especially if you're like, I'm lying in bed and I am getting a lot of sleep, or I feel like I'm not tossing and turning all night, but I'm still exhausted, or I still feel as if I didn't. So that's where you got to look deeper than some of the conservative things that we'll get into. And especially if you're someone who's like, wow, I do all of those things. And despite that, I still really struggle. That also points a bit more to, well, is there something else going on? Because that's when you want to look at those things, especially when it's not because of something more obvious or easy to address. So.
I think that looking at sleep monitors in this setting is also worthwhile. Everyone, if you've listened to anything else, I do a fair bit of monitoring. So
we're all data whores here.
Yeah. So what just alluded to there was that you need to sometimes be in bed for 9 hours to get 7 hours worth of sleep. And why that is because throughout the night you will wake up, even though you don't recognize you wake up. And so during that period of time, surprise, surprise, you're not asleep. And so you lose that sleep duration. But to actually pick that up, you actually need to monitor it. And so what I suggest you do is look at a couple of different monitors. I always take the attitude that they're all wrong, but they're all stably wrong. So that means you basically get yourself a baseline, and then you see how it moves from that baseline. The baseline might not be real, but it's
how
a
it
baseline. How it changes relative
itself
to your baseline is probably useful. I use Aura and I use Whoop, neither of which have I got any deals with. So we have no commercial,
kickback.
There's no commercial stuff going on here.
I can't offer you an affiliate code for this stuff.
No, sorry. Interestingly, what I find is that Aura matches my sense of restfulness when I wake up in the morning. So if I look at the deep sleep component on Aura, it pretty much matches how I feel when I wake up. Okay. Whoop does not match. Like, we will say you had an hour and 20 of deep sleep, and Aura will say you had 30 minutes. And Aura actually more matches my sense of how I've recovered. Interestingly, I have, like, one of my friends is the opposite. He also has got an Aura and a Whoop, and he finds that the Whoop is more accurate with regards to predicting how he feels from a recovered perspective. So it's variable for everybody. Like, if you've got enough cash to burn, sure, go for it, get a bunch. But really, if you're like most of the world, just get one.
Get one at a time.
and see how you go. I think it's a very important thing. The only advantage I would say over something like Whoop is that you can put into it a journal of what you change, and it will help you do a multivariate analysis and help you work out whether it is effective or not. What I've done over a number of years now is, like, I'll test something, I'll see if it works. If it works, I continue it. If it doesn't work, I chuck it out. And so I've got I essentially then stack, a number of behaviors, which means that improves my recovery substantially and my sleep substantially. And I've got rid of all the stuff that, make it worse. So that's been an effective means of using Whoop for me. It's definitely worthwhile considering. And the reason for that is that all these improvements are tiny. They are like 3%.
Well, I was just going to say, and we talked about, like, with pain.
How do you pick a 3 or 5% improvement?
Yeah.
I can't pick that. But
and that's the type of thing where one doesn't sound like a lot, but if you get 2 or 3 of Dan's 3 to 5% improvements, oh my God, you improve your sleep 15%. So and you can't change what you don't measure or what you don't have data on. You can't manipulate or have an awareness around, which is the only way to improve it. Really.
So sleep disorders, let's talk about that. Right. So insomnia is effectively difficulty getting to sleep, staying asleep, or getting back to sleep. And so that's sort of, we talk about, in insomnia in a whole stack of different ways, but that's effectively what it is. You can't get to sleep, get back to sleep, or stay asleep. There's a range of other sleep disorders that we'll talk about. Today, we will, with all our conservative measures, we're effectively talking about managing insomnia. And Juz will take you through all that stuff. There's a range of other different disorders. So narcolepsy is essentially the first disorder. So what that is, it's a neurological abnormality where you are not controlling your sleep-wake cycle, basically. And effectively, you are getting triggering off of your sleep mechanism and you fall asleep. Pretty much it. So it becomes very dangerous for people to be driving cars and all that sort of stuff because it's an actual neurological disorder where you just go to sleep. Also, it results in significant sleep throughout the day as well. And there's a number of mechanisms to manage that. We manage that with medications much of the time. So that's one to speak to the sleep physician about.
Yeah.
Sleep apnea is probably the next one. So sleep apnea is where you stop breathing throughout the night because you obstruct your airway. There's a number of different causes. Some of them are neurological, many of them are mechanical. So you get soft tissue that falls back across the back of your throat, and essentially it obstructs it. And what happens is you drop the amount of oxygen that is in your blood because you're not breathing. That goes on to have significant health implications across the board, across cardiovascular disease, cancer, blah, blah, blah.
And there's a huge link with depression also and apnea, an overlap. Like a very large percentage of people who have apnea also struggle with depression. And
it's very difficult to pick up whether you do have sleep apnea because you're asleep. So you're in that setting if you have a partner that tells you you snore like a train, or that they tell you that you stop breathing in the and they have to poke you.
You'll snore and then be quiet and then
breathe.
Snore. Yeah.
That's a little trigger to go, okay, I need to go and talk to the sleep physician, and they'll take you through a sleep study and do a bit of an analysis there. Under the bucket of sleep disorders also sits restless leg syndrome. So restless leg syndrome is kind of how it sounds. It's like this perpetual motion of your lower limbs. It doesn't stop. That for us, when we're thinking about it, sort of more goes into the motor dysfunction rather than sleep dysfunction.
Or in the context of central sensitization, you look at it a bit more.
We look at it slightly differently.
If someone who does not have sensitization can have restless leg syndrome as its own disease process, like we talked about. Yeah.
So, but it generally comes under the management of sleep physicians. That is something also that they manage with a range of different medications, sort of gabapentin, pregabalin, dopamine agonists, etc. So,
is that another one, Dan, that you'll try to kill two birds with one stone from a medication perspective? If like a sensitized patient has restless leg, and you'll go with this one of the ones you just mentioned that also.
Very good question. The answer to that is I haven't thought about it that way before, but I will now. That's a great idea. From now
on.
Yeah.
Winner.
Thank you, Charles.
Right. No problem.
I get smarter. Then there's the circadian rhythm disorders. So that's basically where you're going to sleep late and you're waking up late, effectively. And that comes with shift work disorders. The easiest way to think about that is that jet lag goes into that bucket of disorders. And then you're getting into the parasomnias. So parasomnias are kind of the interesting one. So what normally happens when you sleep is that you're paralyzed. Okay, it sounds a bit scary, but we do it every day, so it's okay. And the reason why that's happening is that as you're dreaming, you are not acting out what's taking place in your dream.
Right.
So
there's a guardrail in place.
Yeah, there's a guardrail. And so the parasomnias are then things when you are doing stuff in your sleep, like sleepwalking, baking cakes, etc. Yeah. Where you're doing things within your sleep that you really shouldn't be doing because you should be not moving and asleep. And so what's happening there is you've lost the paralysis component of the REM sleep cycle. As a part of parasomnias is a thing called REM sleep disorders. And that's where people will thrash and throw their arms around and move all over the place. Because what they're doing is they're acting out their dreams.
The dream.
I watch my dog act out his dreams. He's obviously running. He's running.
Obviously running. Wild fields.
Bingo's got a REM sleep disorder after I don't know, what do I do?
Bingo needs an aura.
Anyway, so when that's taking place, once again, the paralysis component of the REM sleep is not working on your acting out. And so you can be quite violent within that, somewhat dangerous for partners, etc. One of the things that's really important to know about REM sleep disorders is that they are common in people that go on to develop Parkinson's disease and other neurodegenerative disorders. And it essentially, you'll present with the REM sleep disorder in your 30s.
First, way before.
But you get Parkinson's in 60s and 70s. So if you do have a REM sleep disorder or your partner's sick of you throwing your arms and legs around during the middle of the night, it is something you can go, hang on, this might be a precursor to something like Parkinson's and something you address now. And so
treat it.
Treat it. Go and see somebody, start monitoring it, and see if you can actually prevent some of those things.
Yeah.
I'm sure, although we're not great at prevention of that stuff at the moment, we will be in the future. So
and sometimes it's hard to care about stuff you're doing when you're unconscious or sort of don't feel or realize. But the effects are not good.
And the last one is hypersomnias. So hypersomnias are, as they sort of sound, lots of sleep. So that's where you are.
Oh, that's the disorder Bean has. That's the disorder my kitty cat has. Sleeps 14 hours a day.
Just got a new
Both
cat.
are pets. Oh, God, I do. She's in the couch right now. I can't show her. She's deep in the couch.
So hypersomnia is where someone has an apparent, reasonable amount of sleep or appropriate sleep, but then go on to sleep, a vast amount
Anyway,
during
way
the
more.
day at any rate. Someone might consider this to be normal teenage activity, which it probably is to a certain extent, but my kids should still get the hell out of bed and get on with it.
Is there any correlation to age, like when this type of thing develops, or is it harder?
Hypersomnias. I don't know. I'd have to have a
I don't
look at
know.
it. As I
Okay.
said, definitely not
Yeah.
a sleep expert. My sort of process with this, I look to want to be able to identify when I'm talking to somebody, I'm looking to see, is this insomnia, which we're then going to try
Right.
and manage
Right.
with conservative management strategies, i.e. your conservative management strategies,
Right. Right.
or is this a sleep disturbance and I'm going to send them off to see my friendly neighborhood
Right. Trigger
sleep
referral.
physician. So that's what I'm just trying to pick.
Totally.
All right. Okay.
Should we get into meds a little bit
Yeah,
based upon
meds. Look,
these? They're not great.
no, they're not
You want to
great.
stay
They're not
away.
great
And
options.
this is also what messed me up over years was all the different sleep medications then to treat sleep and taking those long term when they're not meant to be long term, which Dan will explain. So it's
Yeah.
similar to other treatments with pain, whether opiates or other things. It's like, yeah, you want to stop the bleeding, but you don't want to be dependent on them long term if you can help it. So it's good to cover though.
Yeah, look, there's benzodiazepines, which are, your diazepam, Valiums, temazepam, etc. All your PAMs, basically. They differ based on their half-life, which basically means how long they last in your system for. They do induce sleep. It's probably low quality sleep, and they are wildly addictive, which is problematic. The other major problem with the combination of benzodiazepines and opioids is you're more likely to die. So it
The respiratory.
increases your risk of death due to drug-related issues substantially.
Yeah.
So I try and avoid them at all doses. I rarely prescribe benzos. The next component is then non-benzodiazepine receptor antagonists. So these are your Z drugs. So Zolpidem, Zapolone, all that sort of Imovane, all those sort of things that sit in that bucket. Now, they have less side effects, but what they do is they've got more psychotic side effects, and particularly
more of the sort of severe, worrisome
yes,
side effects, less of the
well,
common everyday.
no, they trigger off psychotic events. My first experience with these medications was when I was working in an emergency department many years ago. Geez, actually
many
20
moons
years
ago.
ago. So 20 years ago. So in Australia, I think the main one is that we saw at that time was Stilnox. And this patient, young, had presented with an acute psychosis where her partner had found them on the top of the stairs going to the toilet.
Nice.
Never had a psychotic event before, but had a couple of glasses of red and a Stilnox, and then had an acute psychotic event. And I think that, within the air industry, there's a large number of like crazy stories of people that have a Stilnox, glass of red, and then have a psychotic event on the plane.
Infamous. Oh my God. Yeah. That would be bad.
So if you are,
so don't fly.
If you are using those sort of medications, you've got to be very cautious with the use of alcohol in that setting. So very, very, once again, I don't prescribe them. So melatonin obviously fits into this area. And so melatonin helps improve your circadian rhythms and cycling. More recently, there's been orexin receptor antagonists. So orexin, I firstly came in contact with orexin as modafinil. So modafinil is used to treat narcolepsy and a range of other sleep disorders. And what it does is it promotes orexin activity and wakes people up. And it's one of those things that's also used as a nootropic. So it makes you smarter. Orexin antagonists, which actually block orexin, put people to sleep. And so they're relatively new over the last probably 5 to 10 years. And I've seen more people coming through my room with them taking them at the moment. So they're another option. One of the interesting things with those is that there's an increased risk of suicidal thoughts. So if you do go onto it and all of a sudden you're not happy with the world and have increased
what
suicidal
variable
thoughts,
changed?
it might be the drug. Other medications like amitriptyline, trazodone in the US, mirtazapine, good for promoting sleep. And, as Juz referenced before, if they're struggling with sleep and have pain, that's amitriptyline is my first go-to. Very easy to control from a dosing perspective, so I like it. Antihistamines, that's sort of like old school, sort of, the kid, give the baby some Venergan so it goes to hell to sleep. Old school, but they still do work.
Still works.
Gabapentin is also used to help with sleep in some circumstances. There's so many problems.
Usually it's,
once again, not something that I use for that reason. Larger side effects with weight gain, cognitive dysfunction it causes in
I'm just feeling lethargic in general, not just like sleepy when you want to at night, but kind of.
Yeah. And then the last one that's interesting, which we've seen, and I don't know whether it's just a Melbourne thing, is the use of quaterapine or Seroquel. It's a dopamine receptor antagonist, I think. What it does is it pushes up levels of dopamine, also alters 5-HT1 as well, which both of them affect mood and it's generally an antipsychotic. I've read elsewhere that it may act on histamine receptors as well to help promote sleep. I'm not a big fan of it for sleep disturbance. It is quite effective for managing sleep disturbance. I anecdotally find it very hard to shift people's pain once they're on Seroquel or quaterapine.
So interesting.
Look, that is 100% anecdotal because I can't find that reference or that experience within the literature. But I have spoken to a couple of colleagues recently about, are you seeing this happen?
Did you notice?
And the reason why I've started to see is because previously we used to see Seroquel just used for psychotic disorders. And so I'd always put down to my inability to change somebody's pain to their underlying psychiatric condition.
The other issue. Right.
Other issues.
You see less people then if it's being used for just that as opposed to more.
Yeah. But more recently, I've been seeing an increased number of patients that are having it prescribed for sleep. So no underlying psychotic disorder. Right. And I still can't change their pain. And so that then, well, that's the common piece. Is that it? Yeah. Anyway, it's difficult. I think by the time someone's using Seroquel on you to help you sleep, you're really struggling. So
hopefully, you should have exhausted a lot of other stuff.
I've always been very reticent to change it, but it makes me a bit once somebody's on it. All right.
It makes you sad. Like people on opiates makes you a little sad.
Yeah, that's a terrible combination. Opiates and Seroquel.
Not good. But we have anti-anxiety meds, the sweet spot.
All right. Moving on. So that's the medical piece.
Particularly if you have sleep disorders and it's really intrusive and it's more of an emergency situation too. So another thing that dramatically can affect sleep that is a little bit under the behavior, but a little bit also under the sleep disorder bucket of things like we're talking about is snoring. And this one, to my knowledge, I don't actually have personal experience with for once, thank God. Yes, but Dan does. This is the episode of Dan has the experience.
All right, yes, snoring.
So tell us a little bit about, the snoring.
All right, so snoring. So what happens when you snore is that the soft tissue at the back of your throat fall down effectively. And as you're breathing in, they vibrate. And that then gives you the normal sort of snoring type sound. And there's a number of different things that then affect that, which include jaw position, your nose, allergies, et cetera, et cetera, et cetera.
Past dental stuff, Yeah,
that you can do to change it. So here, what I thought I would do is I just sort of reflect on one of the things that I used. So my snoring was like terrible. And now I sorted myself out.
Now you're snoring champion. Yeah.
Once again, we have no affiliation with this app. I'm going to say it's one of the best apps I've ever seen before. So this app's called Snore Lab. If you
have loved this app since you first mentioned
this
it.
app is a great app. Oh my God.
Best app ever.
So from a practical perspective, it does a number of things. If you buy the paid version, which I suggest you do, it will also give you access to a thing called Snore Gym, which teaches you how to do all the exercises to improve the strength of your throat muscles and your tongue and all that sort of stuff, so that you can better maintain your airway overnight. But the thing that's really smart about it is it's a combined biofeedback tool that then links you to solutions. And so what this app does is you log in and you do a little history on it. And so it asks you a bunch of questions and takes you through, well, your snoring is probably related to X, Y, and Z as a starting point, and we suggest that you try X, Y, and Z.
Yeah, so it's coaching strategies. You. It's looking at your problems, and then it's matching the interventions or the behavior changes. And
so from a simple perspective, what it then also does is, like, you just let it record overnight. So it records how you sleep, and it then rates it, and then you can then use each one of these interventions, and you can see if it works.
Test, change one, see.
Change one. Does your snoring get better or not? Yes or no? Yes. Great. Keep doing it. No. Get rid of it. Go on to the next one.
Yes.
And the other thing that they do is they link to products within the system. You can then just buy off websites, or you can buy off Amazon, which I'm sure they're getting kickbacks for. But you know what? If the thing works, it works. So if everyone's making coin and you're getting better, that's fine. Right. So a number of the strategies that within this, the use of nasal dilator. So there's a thing where you put a little thing that holds your nose open.
Flare them naturally.
Yeah. So mouth guards, where you basically use the mouth guard and it pulls your jaw forward. And so basically by pulling your jaw forward, it opens up your airway, so you stop snoring. They have a recommendation around a range of different pillows. So you can get a wedge pillow, so you're not laying super flat. And so your head's not going back, and then you're not and then you're not obstructing your airway. And then another pillow that you can't get in Australia, which is a bit annoying, is that triggers you to like lay on your side. And there's other strategies that you can use, where you use a little backpack, that you put a little backpack on your back, which, well, I cheated. And so what I did is I wanted to see if I can make that work. And so I just used a Camelback. It's essentially a water bladder in a little backpack. And instead of the water bladder, I put in a towel and I put the backpack on and I slept. And so what it means, every time you go over, you can't lay on your back because the towel's
right. It keeps you.
But it keeps you on your side.
One side
and so by keeping you on your side, it then, And so
that is cool.
It is kind of smart.
Because it's going through what things are causing you to snore and then giving you
and interesting didn't work for me, so I got rid of it because it wasn't that uncomfortable. But it didn't work. But anyway, so the app is excellent, and it does allow you to get so my snoring went from like crazy, like really loud, and for most of the night to just soft. And
like a baby.
Like a baby.
like a baby.
My wife doesn't want to kick me out of the room anymore. What I did in that, though, as well, is it became apparent to me, and I'd worked through a whole stack of stuff, that my nose was also the problem. And so I knew I had a nasal septal defect. That's what happens when you like fight for a whole second line. If you're watching the video today, you can see my
It's not a zit. It's a raspberry.
It's the move your head, Dan. I was sparring with a big fella yesterday. He was light, but he was like 6'4", so he's got the world's longest arms. He was like pinging me from the other side of the ring. Anyway, move your head, Dan. Nonetheless, what goes with boxing is that sometimes your nose gets broken. And so when it's broken on the inside and it's bendy, that's called a nasal septal defect. And as a result, you don't breathe very well. And that was where I was going. And what I found is that I tried all these different techniques. I put off getting my nose fixed and went, it's just got to be done. So I got my nose fixed. And then all these other things started to work. So just fixing my nose by itself wasn't the trick. I then found that all these other things that I couldn't get to work now worked. And so that sorted out my snoring. So
you got like a big 40% or whatever. And then some of the smaller things have more of an impact or can actually make an impact, similarly as with pain. Yeah. Like if you get one really important thing sorted, other things start to fall into place and have an impact, whether other conservative strategies or medications. So this is actually a really good analogy for how you treat pain in general or something very specific.
So we've rabbited on
already
for like an hour now. So I think what we'll do is let's wrap this episode up, and we'll do this as 2 episodes. We'll go through all the conservative stuff next
time.
Next episode. Next time. Same bat time, same bat channel. And we'll go from there.
Yeah. All right. Thanks a lot for listening, guys. Make sure if you are not yet signed up for our official newsletter, we're sending them out after episodes now, and they contain a lot more information as well as our website around what's in episodes, right? Summaries, things that are from a written perspective. If it kind of feels like it goes in one ear and out the other when it's verbal. So make sure you're signed up for the newsletter, www.iniyh.com/newsletter. We'll throw it in the show notes too. And that way you can get all the accompanying information. All right. We'll see you guys next time, tackling more sleep. Bye.
Thanks, guys. Bye. Thanks for listening. Clearly, this is a podcast. It's for informational purposes. It's not a consult, medical advice, or the practice of medicine, and it doesn't form a therapeutic relationship. If you feel the information might be useful for your situation, before applying it to yourself or others, you should speak with your doctor or your treating clinician. Do not delay in seeking a diagnosis or treatment, and applying the information is at the listener's own risk.